Okay, everybody. Well, we're going to get started. It is at the top of the hour, so as people filter in, that's fine. But we're going to start with our webinar. We have a couple of announcements starting off. It's been quite a busy week for different webinars and offerings, but hopefully you've been able to take advantage of those. We had a health equity hour just prior to this webinar at 3 o'clock with Alethea Carr, which was fabulous. And then tomorrow we have our sepsis webinar on chorioamnitis, which will replace your sepsis meetings for those of you on the sepsis committees. We've had a couple of offerings from OBI, and so it's been a lot of great education towards this end of February. As a reminder, our next webinar for Michigan AIM is March 25th, and that is going to be a legislative update. So we're going to hear a little bit about what the legislature has done to aid in maternal health and well-being. So that should be good. We've got a lot of great announcements and things that have been passed as of late. So that'll be a wonderful summary of what's going on in the government. Today, we wanted to present a little review and some tips for hypertension. What we thought we would do is review our Michigan AIM hypertension protocol, the bundles for which we are educating staff and physicians, and then of course auditing. And then from there, we're going to talk about some tips as to the success of what some of the other hospitals are doing. So what you see right there on your screen now is our scorecard for 2025. This is what Michigan AIM is looking at when we talk about the data that we're sharing with Keymetrics on our hypertension bundle. So a couple of ways that you can get points, just to review. The first way, of course, is your chart abstraction. You want to abstract at least 20 charts a month. And of those, what we're looking for is that 80% or more of those cases had a follow-up appointment scheduled. So that means that if that patient had severe range pressures during her admission, we would want to see a 3-day follow-up scheduled before she is discharged home. If she did not have severe range pressure, but rather had a diagnosis or history of hypertension in that pregnancy, then we would want a follow-up appointment no more than 7 days following discharge. And for that measure, you get 5 points if you reach that 80%. The other way you could do that is if you showed improvement. We know that this was a rather new component of the scorecard last year, and that sometimes it takes a little while for that to pick up speed. So if in 2024 versus 2025, you had a improvement in your compliance.
I know, but is that what?
Sorry, is someone speaking? Okay, thank you. If you had an improvement in your compliance for this measure, you would get 3 points. So we don't want to discredit anyone who's showing improvement, as we know that this measure can be somewhat difficult to obtain. In addition, however, you do want to see that your cases of severe range blood pressures, so as a reminder, that includes blood pressures that are 160 or greater systolic, or 110 or greater diastolic. And if you can see that that has been treated within 60 minutes, 85% or more of the time, you would get 15 points. For smaller hospitals that do not have a large proportion of their patients that have severe range pressures, then we would qualify you with 75%. That would be less than 15 cases though. So we would want your denominator to be 15 or less in order for us to take the 75% compliance. Or again, the other way you can get 15 points for a total of 20 for the hypertension measure is that you show improvement in your time to treat from within 60 minutes from, again, the calendar year 2024. Some of our hospitals are new to the hypertension protocol, and therefore, if we do want to give credit if you've shown some improvements from one calendar year to the next. So that's just a review of our scorecard for this year. Of course, if you have any questions, we can certainly communicate that to your team or to your C-suite, but that's how we're measuring the 20 points on the hypertension bundle. Next slide. Um,
Madonna.
yeah,
Donna, this is Gina from
hey,
Holland. I just want to clarify something because in the past it's been a little bit confusing and some of the folks may be new on this call from other years, but that
sure.
denominator of 15 in the past has been for the entire year. So that's places that
Oh,
get like one or two
right,
patients a month. And
right.
um, so for those of you that just got hope that you have 4 or 5 a month like we do, and that would
Yeah,
be super helpful, you don't get 75, you're 85%. I just wanted to
right.
let you know because that was
Yeah,
something that sometimes is a little confusing. So
right.
thought I would just throw that out
No,
there.
I appreciate that. Sorry if I didn't say that. So we should probably add that just for clarification. As Gina said, we could put for smaller hospitals with less than 15 cases annually, then that would be your denominator. So very good point. I appreciate it. We do have some hospitals with very small populations and therefore they're only getting, one or two cases a month. That is true. That's applicable. Anybody else who's getting a steadier stream of patients that have severe range pressure, we do strive for that 85% compliance. So thank you, Gina, for that. Appreciate it. Okay, we'll continue. Um, so a lot of feedback questions come from the recommendations and the bundle guideline. I have a lot of questions surrounding the hypertension protocol, how we came up with the range for severe range pressures, how we came up with the blood pressure monitoring. So I wanted to bring up this slide just to show you that this was an ACOG guideline. We take all of our bundle recommendations from ACOG and from CMQCC. So they are evidence-based. I always want to be sure that we communicate that and that we make sure that everybody knows that the things that we do are evidence-based. So as you see here in the section of ACOG that recommends our treatment guidelines, antihypertension therapy for women, especially in the postpartum period for postpartum hypertension. If you have systolic blood pressures of 150 or diastolic of 100 or higher on at least two occasions that are at least 4 hours apart, you certainly want to provide treatment. That's not necessarily severe range. That doesn't necessarily mean you go for the labetalol or hydralazine, but rather you want to suggest to that woman that she seeks treatment because those are significant elevations in blood pressure. For persistent systolic blood pressure or diastolic blood pressure of 160 or 110 respectively, then we need to treat within that hour. And that comes from ACOG. Blood pressure monitoring here, you see recommended 72 hours after delivery or outpatient surveillance. So again, once they're discharged, we want that 3-day turnaround. And if there were other symptoms, or if there's not necessarily severe range, but rather hypertension diagnosis, then you would want that 7-day turnaround. So that is kind of coming, that comes right from ACOG. So, all right. This was a nice slide presented to us actually by a hospital that was trying to be very helpful to the staff so that they knew exactly how those appointments needed to be. So we use this on our unit just because it's so much easier to look at this sort of graph than to count. But anyway, it just makes it easier. So for our patients that need those follow-up appointments, if they're discharged on a Monday, that appointment needs to be made by Thursday, or the appointment needs to be made no later than Thursday, Tuesday for Friday. And then we adapted it so that if you have offices that are, of course, most likely closed on the weekends, this is what that would look like. For a Wednesday discharge, you schedule that appointment for Friday. Same with Thursday. And that way you are making sure that they are seen before that long weekend. So this is just easy. We'd like you to use it if you want. Easy for the staff to read and make sure that they can schedule those appropriately as they look at that little graph. All right, next slide. And then this is a similar feature with the 7-day postpartum blood pressure. So if you have a patient who was discharged on a Monday, they would need to be seen by the next Monday and so on. And then of course, for those patients that are discharged Saturdays or Sundays, you would want them to be seen by that following Friday. That would give you that 7-day window. Okay, so I wanted to share with you just some of our data because I know that hospitals are struggling and they want to They want all those tips and recommendations and how are you doing it and how are you successful. So I wanted to share with you our 2024 compliance. This, of course, is, shows for, the audience that it's not a perfect science. We're not hitting the mark every month. We've had some successes, but it ebbs and flows. We have an action plan in place for how to improve that in 2025. But our overall annual compliance in 2024 only hit 65%. It was our newest, measure, of course. This was something that we just implemented last year. So we had a little slow startup, but we're hoping as 2025 rounds out that we'll be able to improve that. What we've decided to do is take the financial incentive that we receive from the state for our Joint Commission maternal levels of care and use that as an FTE toward a nurse navigator. When we were looking at all of our Michigan AIM bundles, what we found was that this was our biggest gap in care, and we thought the best use of that money and incentive was to have someone who is in the role of something like an OB case manager. We know from other units of the hospital, different bundles throughout the country, that there are case managers that set up follow-up appointments, that set up home health care. They set up for medical equipment, oxygen, et cetera. But we don't see that a lot in OB. We don't see that a lot in the postpartum period, which really does a disservice to our patients, especially because we know from all of the work we do how complex their care can be. So we've introduced to our care team an OB nurse navigator, and her responsibilities will be to not only schedule these hypertension follow-up appointments, but perform the needed teaching for discharge, share with the patients and family members the early warning signs, coordinate care if they need more than just hypertension follow-up, but rather things like WIC, breast pumps, car seats, things like that, any of those resource needs. And then, of course, to take a look at other therapies outside of maybe just the traditional, like physical therapy, if they had a difficult labor or delivery and they need a consult to PT or the consult to other service lines. That is what that staff member's role is. So far for the year, it has helped us obtain a much higher compliance with our hypertension follow-up appointments. And we're looking to see a great improvement in this year's percentage. So I just wanted to share that as an option or an idea if you were looking for ways to utilize those funds and we did have our Joint Commission, just to veer off for a minute, we did have our Joint Commission survey visit for maternal levels of care, and the surveyor really did like that component of our healthcare team, thought it was very beneficial, integral part of how we educate our patients and perform those follow-up appointments. So that was really nice because to give us a little bit of accolades for the utilization of that position. So just wanted to share that. We can continue. Okay. Oh, and that's kind of what I said there. So again, she reviews high-risk patients. She performs discharge teaching. She's utilizing the maternal warning signs, schedules follow-up appointments, will provide blood pressure cuffs to those qualifying patients. One of those things that we know that our staff really don't have a lot of time for, nor do they have a lot of background, is looking at the various forms of insurance. So many of our patients have insurance that covers a plethora of resources, including home medical equipment or even a follow-up home nurse visit. And we don't utilize those a great deal, especially in OB population, because it's typically thought of as a very healthy population. We know otherwise. So part of this role also is going to be looking at the various insurances and what those insurances offer our patients in terms of maternal child care. We do know that a lot of the Medicaid companies are looking at starting to do their own incorporation of the AIM bundles because of the incentive that they're given from the state. So it's all going to become very intertwined and connected. And if we have a patient with, type X insurance who qualifies for a home health visit or whatnot, it's part of our role to make sure that that is arranged. So I think it's gonna work out great, but a lot to learn. So we'll see how that goes. Okay, next slide. Okay, so this is just a quick little screenshot I wanted to share. And we also know part of the concern with this bundle implementation is where are we documenting that these patients have a follow-up appointment? We know everybody has different, EMRs. We've got Epic and Cerner and there's not necessarily a way in all of these EMRs to run reports. So a report would be fabulous, but because that's not always possible, we had to educate our staff as to where their appointment should be documented. So we have an interdisciplinary discharge plan, and it will populate to discharge instructions for our patient that we can print out and give them on discharge with our teaching. But as an auditor or an abstractor, they need to be able to see that as well. So I just wanted to share a little screenshot of where our staff is documenting those appointments. And that makes it very quick and easy for us to say, yes, we have it scheduled, it's documented, we're compliant, and then we can move on. So that was just a little bit of a screenshot there for a patient discharged on the 21st who needed a 3-day turnaround appointment. Next slide. Okay. Also in review, just wanted to go through a little checklist. I think sometimes when we're talking to our staff, there's always a request for a quick and easy checklist, quick and easy reminder of how to do our vitals. So I threw this in there as a resource for everyone. We like it here through the DMC, and we even made badge buddies. We had a hypertension task force where we had some of the staff sit in on a little day-long conference. And at the end, we passed out these badge buddies. So it reminds us that, of course, after severe range blood pressure is taken, we should be taking it again to confirm that it is, in fact, severe range, and then initiate our treatment within 1 hour of that severe range blood pressure. First line therapies as a review is, of course, labetalol IV push, hydralazine IV push, or in the absence of an IV, oral nifedipine, immediate release, not extended release. Some of our providers will then want to order preeclamptic labs. It's not always necessary if we're not sure that that's what this is, but of course, certainly something to think about. We don't have to have a diagnosis of preeclampsia, though, keep in mind, to treat severe range pressures. We should initiate seizure prophylaxis, consider antenatal steroids if this patient is preterm and we're trying to hold on to the pregnancy. VTE prophylaxis, especially if those patients go on magnesium. Utilize, of course, a catheter. So continuous EFM, this I put as needed simply because some of our patients are, of course, delivered. And then we want to also document our blood pressure as we utilize our magnesium, should we start that. So Q 15 minutes for 2 hours, Q 30 for 1 hour, and then Q hour for 4 hours. We will pad the side rails, encourage a quiet environment, and then perform patient education and debrief with the staff as needed. So little quick and easy checklist for our staff to remind them. Next slide. Here I have the next 3 slides are just, again, a nice resource. ACOG published a really great hypertension protocol PowerPoint. It's about 30 pages long, but in those pages, they've embedded the labetalol algorithm, the hydralazine algorithm, and the Procardia or nifedipine algorithm. So this is really helpful, especially because not everybody has these memorized. So it's helpful when we consider how often and how quickly we can repeat the use of those medications. So if we choose the labetalol route, this shares with us how often we need to repeat the blood pressure and when we can increase the dose of labetalol. So we go from 20 to 40 to 80. And then, of course, we would consider switching to hydralazine. So then the next slide is in similar fashion, the hydralazine algorithm. So this starts at 5 milligrams or 10, provider choice, depending on other factors. And then we can repeat that and increase it to 10. And then we would consider labetalol 20 milligrams. So this is sort of helpful when it comes to deciding what protocol to follow. And then the next slide is a reminder of the immediate release oral nifedipine algorithm. So we use immediate release oral nifedipine 10 milligrams, repeat our blood pressure and then consider administering it again before
Yeah.
we follow
Are we doing
the protocol for labetalol or hydralazine.
We're doing Disneyland on Monday.
If we could all mute our lines, that would be appreciated. Thank you.
Branded until 10.
Thank you. Okay, so and then after that, I just wanted to review all those so we can go on to the next slide. Okay, so before we go on to Dr. Mariona, we are going to have Dr. Tribbewasser from Michigan Medicine talk about her the success that they've had there and how the compliance to the bundle has been working for Michigan Medicine. Do you have slides you want to pull up, Dr. Tribbewasser?
Yeah, Naomi said she would pull
Okay,
them.
perfect. Great. While we're pulling those up, any questions? I'm also going to be looking at the chat during the next couple of parts, so I'll be able to answer questions through that as well. So please don't hesitate, and then we'll have Dr. Tribbewasser go ahead.
Right, thanks. Just to kind of reiterate what Madonna had already brought up on the severe hypertension follow-up, that ACOG recommends that follow-up within 72 hours of discharge, because postpartum exacerbations are common. And the SMFM Patient Safety and Quality Committee has taken that recommendation and does offer some guidance if hospitals want to use an ICD and CPT based way to abstract instead of having to do a more manual process, especially if you have maybe higher volume. That is available in a publicly available QI document, but they basically have the CPT qualifying codes in the numerator are visit codes, including potential for telemedicine visits. And then the denominator CPT codes are patients who've had a delivery and or have a severe feature diagnosis, HELP or eclampsia. Next slide. So the way that we have handled the recommendation for postpartum hypertension follow-up at Michigan Medicine has been for the past couple years using a remote blood pressure monitoring program. Ours is called My Heart because everything starts with an MI. It's a remote blood pressure monitoring program for 10 days after hospital discharge. We offer this to everyone who has chronic hypertension, gestational hypertension, preeclampsia, HELP, eclampsia, and a subset of our patients from our cardio OB clinic who may be at higher risk of having an adverse event in the setting of elevated blood pressure should they become hypertensive at home. Patients are given a blood pressure cuff at discharge if they don't already have a validated cuff. They get twice daily text reminders on starting the day after discharge to send in a blood pressure morning and afternoon. And then they get automated feedback based on their systolic and diastolic blood pressures. So that feedback, if it's a normal blood pressure, would tell them like, this looks normal, please keep monitoring. If it's elevated, they will get a message to say either this is mildly elevated, keep an eye on it, or this is high enough that you may need treatment. Someone will reach out to you. We get flagged values to a provider inbox in Epic if the systolic is above 150 or the diastolic's above 100 to trigger a potential for either starting or up titrating medications. And patients also get additional texts if their blood pressure is elevated to ask about symptoms of preeclampsia. That inbox initially was monitored by myself and two of my MFM partners, and it's currently monitored by one of our triage midwives who is on as a virtual triage provider during the day. They do some virtual triage visits, and then they also manage our My Heart inbox. They then perform virtual checkout visits at 10 days where the midwife reviews their medications and does counseling on risks of hypertensive disorders, including potential for recurrence in a future pregnancy, risk of ongoing cardiovascular disease, and a recommendation to schedule follow-up with a primary care provider or cardiologist. One of the reasons that we have had, if you can stay there for just a second, pretty strong hospital support for this type of program has been that we have also started discharging patients sooner. So there was significant access issues in our birth center, and with MyHeart, we have started doing some earlier discharges for patients who are hypertensive if they will be in the MyHeart program. And that discharge timing depends on whether they ever had severe features, what their blood pressures currently are, and whether they need to continue inpatient care based on uncontrolled blood pressure, worsening labs, or symptoms. On the left side of this screen is just the patient brochure that goes through our OB triage number, signs and symptoms to worry about worsening hypertensive disease, lets the patients know when they will be contacted, how to check their blood pressure to get accurate readings. And we are sending patients with Omron cuffs that are validated for pregnant and postpartum, how to report their blood pressures, and then what to expect after they send us the text. On the right side of the screen is part of the kind of Epic tracking report that we can see. So this is listing 5 different patients in the 5 rows who have been recent enrollees in this program. And it will tell us how many days they've received text messages, how many of those days of the 10 that they've replied back. So you can see like the second row, someone received texts for 10 days and replied half of those days. Many of our patients reply all 10 days. And then it also will show texts asked and answered. And some people can get a really high number of texts asked if they continue to have elevated blood pressures or are reporting symptoms, because that prompts additional text to that patient. So we can get kind of a snapshot of where our patients are and how we're doing in terms of meeting some of those ACOG metrics for follow-up, both at 3 and 7 to 10 days. The midwives have been an amazing addition to our team for managing this, because we have about 1,800 patients enrolled in this program every year. So it's a big lift if you are otherwise clinical. We've built out some algorithms to help them manage, and then they have an MFM team in the background if they have questions or the medication titration is getting a little bit complicated. This is when we would start a patient who wasn't on an antihypertensive. Based on their blood pressures, we're using amlodipine as our first-line agent postpartum. And then we have the send to triage triggers, either for really elevated blood pressures or symptoms. And then you can go to the next slide. And these are for patients who are already on a medication, and a table for how to adjust those doses. Again, we're using calcium channel as our first line, hydrochlorothiazide is our second line, and then third line is labetalol or enalapril. The rationale for that, which I recognize is quite different than what a lot of people are using, is that labetalol for postpartum patients is actually associated with a much higher risk of readmission than using calcium channel blockers. And that has been shown in observational data, and there's now a randomized trial that was presented last month at the SMFM meeting that nifedipine had a much lower rate of readmission than labetalol monotherapy. We're also using amlodipine as our first line because people tend to get fewer headaches with it, and it's daily dosing. So we're trying to make it as easy as possible for people to take their medications until they don't need them anymore. So some strengths of the program is that we have really high levels of patient engagement, much higher that it's one thing to schedule visits, it's another thing for patients to get to that visit. This allows us to both schedule people and have most patients actually submit blood pressures at that 3-day mark, as well as get some feedback and be able to reach out if they're having symptoms. We have a consistent CNM team with MFM backup, managing the antihypertensives, as well as counseling. Our major limitation at this point is that we still only have the program available for English speaking and reading patients. We have tried to work with our in-house group that builds out the remote monitoring programs for various departments and have just hit a bit of a roadblock in trying to get this in multiple languages. Although with the midwives covering, we do have the capacity to be calling translators. So I think we're at a good spot if we can actually get the messages into multiple languages. And then for patients who decline MyHeart, which is pretty uncommon or ineligible based on language, they would have a blood pressure check scheduled in the office. And I think a downside of that is that they just get less consistent guidance and management strategies for their blood pressures. So that is kind of how we have approached this, and happy to talk with any hospitals or hospital systems that are interested in thinking about remote monitoring.
Great. We will now move on to Dr. Mariona. Are you ready, Dr. Mariona? You're still on. There you go.
Okay. Thank you.
Yes.
Thank you very much. That was extraordinarily important and useful information from both of you, and I'm excited to hear the progress that IM has done in the 10 years of operation. Looking to the future, I sort of dreamed up this issue to try to inspire the next innovation for the next 10 years in order to create an automatic program that could be validated on time in order to insert a real innovation on what you all have been doing with a tremendous amount of energy, dedication, work, know-how, etc. Next slide, please. If I understand that, one of the recent comments from Andrew was that the Keystone Center has now new personnel, new talents, which gives me the opportunity to put some pressure on the system to see if a combination of the birthing centers that can dedicate their own single obstetrical IT collaboration team with a Keystone Center team in obviously a multi-stage process to put in place a system that will automatically operating, it will select the items that can create a risk stratification with a weighted score if it can be developed with clarity and with simplicity attached to the ongoing process of selecting maternal levels of care. And congratulations, Julie, I understand that Michigan now has a level 4 qualification as of recent, and I'm looking forward to see the first delivery of an XY genotype. Next slide, please. So create a system which, for lack of a better idea, I called it clinical outcomes through a daily entry. For short will be code. This will attach itself to the electronic health record, and as of now, there must be a number of birth centers in the state that all use the same electronic health record, and that group could be the initial network with supporting from the augmented intelligence coming from the Keystone Center. The selection will start during the prenatal screening in order to be able to use predictive analytics as of what with the pattern B to identify patients that are at higher risk than expected. For instance, are we stratifying whether a preterm birth has occurred spontaneously or has occurred as a result of a medical decision to deliver prematurely because of the present clinical pathology? Obviously, this adventure will need extremely strong administrative leadership to innovate from what we have now, which is a system that is manually operated with call centers, et cetera, into a system which will automatically enter the variation in clinical changes on a daily basis, on a weekly basis during the prenatal care, on a daily basis during the hospitalization and follow postpartum, to identify those patients that are at increased risk for extra pathology, whether it is a stroke, whether it is a readmission, whether it is sepsis combined with anything that has happened during the delivery hospitalization. And finally, the process to validate the program when the program is ready to respond. The objective that I'm pursuing is trying to convert, which is now a potential initiative to modify the system, into a successful statewide clinical care program. Next slide, please. So obviously we will face significant challenges. One of them is the IT vulnerability for each one of the centers and whether or not the individual providers will trust implicitly augmented intelligence as the programs continue to improve in their performance. There is always the factor of resisting change, and we need a system that is trustable, that is reliable, that data collection is of high quality, and that the data entering and abstraction is timely. We need to remember that there continue to be variability in quality of care, whether or not it is related to the maternal levels of care or to just the geographic events. The algorithms to be utilized once the program is validated will continue to be proprietary, but hopefully will be proprietary for the network and not for the individual institution or birth center. And finally, the newer challenge of how to obtain funding for such a program. And with that, I'll shut up and I'll listen to the group. Thank you very much.
Thanks, Dr. Marion. All right, so we have just a little bit of time for questions or even your own feedback as to what is working at your hospital in regards to hypertension protocol, follow-up. So kind of an open forum at this point, and panel discussion, if you will, if you have any questions or feedback on how your health system is doing. We do see, we do get quite a lot of emails regarding some of those, the bundle implementations. So just wanted to give time for anybody who might want to have a discussion about that. And if not, we will have some time to enjoy our little bit of sun. Kristen put in the chat, one of our biggest challenges is identifying patients and communicating that from L&D and mother baby. Any tips or tricks? So yes, we see that in some of our hospitals as well, especially those that have separate labor and delivery versus postpartum units. So I agree that can be a challenge. One of the things that we have discussed, of course, is a comprehensive report. things do fall through, you know, the gap and shift change, things like that. But there should be a comprehensive report given, handoff to one unit or another, especially when the patients have been treated for severe range blood pressures within labor. So to make that part of your report, not just her hemorrhage risk assessment or the fact that they were GBS positive and treated, you know, ×2, but also she had some severe range pressures and was treated once with labetalol. In addition, there are some EMRs that have problem lists. So we definitely want to include hypertension diagnoses in those problem lists and have our postpartum nurses make sure that they are reviewing those when they accept a new patient into that unit. So those are some of the things that we provide education to our staff. Anything from Dr. Mariona or Dr. Trubawasser about that?
Yeah, I was gonna say that we have Epic, and so on the grease board there's like a notes section, and we will write in if someone has like a hypertensive diagnosis, but that grease board note goes away, and so we also have everyone who goes into MyHeart have a problem in their problem list called postpartum hypertension, where it lists out what their hypertensive diagnosis was, what medication they're on, and any other follow-up items, so that that can be seen both while they're inpatient, and then if they happen to call triage or have a follow-up visit come through the emergency department, that's visible to everyone. I think one of our challenges, the Epic sticky note is an interesting thing. I've like fought a battle to get rid of people using our Epic sticky notes instead of putting things actually in the medical record. But it is visible depending on your department. So it doesn't necessarily help you outside of your own department, pending which color sticky note you choose. We have struggled when patients end up in like an ICU or on another service, like helping those teams understand different blood pressure parameters in pregnancy and how much more aggressively we treat blood pressure, that sometimes our patients in the ICU will get like 5 of IV labetalol for severe range blood pressures, and we just have to really encourage people like, here are our thresholds, and share like our order sets for those hypertensive emergencies to try to make it easier for teams that are less used to taking care of someone who's a recently pregnant patient.
See, as I'm listening to Judy, I'm even more interested in reaching the point whereby the use of a human is much less critical in the note writing on the record. So the record will identify the changes in the clinical parameters once those clinical parameters are clearly identified by every unit, and will be different perhaps between a suburban unit from a rural unit, or a unit that deals a lot with non-English speaking population, both first and second generation immigrants into the area. And we see that phenomenon in southeastern Michigan, complicated by the fact that is a number of those patients are functionally illiterate. So the issue needs to be extremely carefully ripened before it's put in operation, because the patient herself and or the family will not be acting appropriately, responding to the clinical findings. So that's why the automating and creating a risk level, if that is feasible, then we will probably be at an advantage. Up to this day, I'm still being asked questions about the use of MAC sulfate, how many days postpartum MAC sulfate is being used, how many weeks postpartum MAC sulfate is being used. It gives me a little bit of hesitation when I hear some of the questions. And of course, there was a lot of information provided during the recent pregnancy meeting, when I'm looking forward to see some of those abstracts published to see exactly what the results are that the researchers have obtained. Thank you.
And then Jennifer added that there is a column added to the patient lists in Epic that providers can use for rounding, and a column on the My Patients page for nurses in postpartum. So that could be a useful tool if you have Epic. Great. Anyone else? Anything else to discuss in this regard or tips for the group?
I think to that point, since we all have like different systems and not the same strategy won't work everywhere, and some of us see like 20% of our patients have hypertension, and some places it's more on the like 5% range. That something that works for your hospital that you can do consistently every time is really important, especially for those like handoffs and figuring out who needs postpartum follow-up. So that may look different across hospitals, but like having a single process helps us keep people from falling through the cracks.
Right. Exactly. Yes. We have several nurses that will say, well, I chart it here or I chart it here. And so I do give them feedback too, that the best way to do this consistently is that we're all charting in the same place and doing the same thing. So it's a good tip. Great.
Madonna,
Yeah.
just a quick question for Michigan Medicine.
Yeah.
Do they do their education for their protocols for MICU, SICU, and ED so that it's shared in all of the disciplines? I just was wondering how that goes.
Good
That is
question.
a great question. We try. It's hard when those are big units staffed by a lot of people. So we this year, kind of leading up into the maternal levels of care, did some simulation training in the adult emergency department, where we had nursing, pharmacy, and physician representatives in the ED. And we did a case of severe hypertension leading to eclampsia and a case of postpartum hemorrhage. We're planning to do the same sims for our critical care areas, recognizing that we can probably reach fellows and faculty to some degree. It's much harder to reach the residency programs just because they're so big. We are planning to do the sim for children's emergency services also, just because some of our younger patients may present there and not to adult. And then I give like a annual lecture to the critical care faculty, both for like anesthesia medicine and surgical ICU, to kind of keep them at least vaguely familiar. But getting big places that kind of education when it's something they don't see very often is a real challenge. And it was called out in our levels of care visit. And I don't have a perfect solution, but those are the things we're trying to work on right now.
That's a big effort, Judy. Have you been able to insert strongly the concept of the fourth trimester? Because as you go into other providers that come into the picture, 1 year follow-up from the time of the delivery is a long time and people lose track of it.
Yeah, we have some ability to at least flag it again with like Epic will flag that someone had a recent pregnancy episode. So it shows up like in their storyboard, regardless of what location of care in our system. Those don't seem to cross across Epics, like where you can see a lot of people's notes through Care Everywhere. Those like flags don't necessarily show up. And if someone didn't start their pregnancy with us, they never had a pregnancy episode to trigger that. So it's like an improvement from not having that at all, but it's definitely not a perfect system. We have had the ED add, have you been pregnant in the last year, to their triage screening questions.
Yeah.
Do you have a designated IT person for your department?
Yes.
Yeah. We have the same thing in our ED triage, where we do have that in the triage band that they need to ask if that they've had a pregnancy in the last year. But just to also to give a little bit more to Michelle's question, keep in mind that even outside of maternal levels of care, the Joint Commission perinatal core measures do require education to emergency department and anesthesia staff. So that would be, if you are a Joint Commission hospital, something that you would want to show proof of anyway, regardless if you're a level 1 or 4, because of the importance of having that point of entry for that patient coming through the ED, whether that's in the pregnancy or postpartum period. So, and that might not include 100% compliance of all staff, physicians, fellows, residents, but they do need to see that there's been some education given to those service lines, just to be compliant with perinatal core measures. So certainly something all the hospitals should be doing. But then, of course, when you look at your levels of maternal care, if you're a level 4, as Michigan Medicine is, you want to have that specialized ICU, education, and of course, cross-training to places like emergency. So, yeah, very, very important and good question from Michelle. Awesome. All right. Anything else? Still looking at the chat. No other questions so far. If we don't have any other questions, just another quick announcement. Please take a look at key metrics in the next couple of weeks. We will be publishing or opening up the ability for all of our sites to complete their structure survey. So that will be important as we tabulate the scorecard for 2024 and start to put out everybody's designation through Michigan AIM. But that structure survey needs to be completed. So please take a look for that to come. Yes, thank you, Allison. It opens up Monday, the 3rd. So that's just coming up this Monday. So you'll be able to log on and see that, complete it with your team. And then that way we can start the journey towards our designation for the 2024 scorecard. Those will be officially announced at the Maternal Infant Health Summit coming up in June, where we'll have, again, a wonderful 2-day conference, hoping that we can have hospitals join us there. That'll be in Kalamazoo this year. And then there's a question, any word on when and how we'll be reporting on race and ethnicity in key metrics. So we did just start that preliminary discussion in the last month. We have not finalized how that is going to be reported. Definitely something we are considering. If we did start it this year, it would not be for points because we know that not every EMR can be that quickly updated. But we will have something more formal and a bigger discussion as we investigate that process. Definitely something important, but that has not been ironed out completely yet. But thank you for the question. We have been starting that conversation.
Well, since you're at it, Madonna, are you going to, or it's already included the zip code and the educational level of the patient?
No, we haven't been doing that I can think of. Some of our sites are doing education level. There is a question about that on their intake, and some of it crosses over to a report. I do not think it's universally asked, however.
Neither is the zip code then.
Right. Everybody turns in an ID of some kind and we do have access to their address, but I don't believe that we run a report on the areas we serve necessarily. We have some, simple demographic information, but nothing that whittles down specifically to zip code.
So in the context of the social determinants of health, as they become more and more important as the time goes by, many of parameters that are non-traditional should at one point or another become part of what we do in order to identify the most important issues that may affect that pregnancy from day one, not just at the time of the delivery admission.
Right. Yeah, absolutely. All right. Well, if there's nothing else, we'll let you out just a few minutes early. We really appreciate everybody's attention. Again, a reminder that we have our webinar again next month on the 25th of March for legislative update. So look forward to that. And once again, please remember to email us if you have any questions. You can get a lot of different pieces of information from our website and in Key Metrics, but please reach out if you have questions or concerns. We would love to help. And good luck to everybody on the hypertension bundle. We appreciate your time.